Good morning, everybody. Welcome to a fascinating session here at the Virtual Global Forum or World Congress for the World Federation of Hemophilia. We will have a free paper session, which is full of musculoskeletal content. And I will start by introducing Dr. Cedric Hermans, and he will be presenting a paper by the following title. It's Confirmation of the Very Low Rate of Subclinical Venous Thrombosis in People with Hemophilia Undergoing Major Orthopedic Surgery in the Absence of Pharmacological Thromboprophylaxis. Welcome, Dr. Herman.
Thank you. Thank you, Adolfo. So it's my great pleasure to share with you the results of our study looking at the incidence of subclinical DVT in patients with hemophilia undergoing major orthopedic surgery. I don't have any disclosure to make regarding this presentation, so no need to tell you that hemophilic arthropathy is a major consequence of hemophilia. No need to tell you that many patients will require in the course of their life elective joint arthroplasty of the knee, the hip, or other joints. We know that DVT, PE are common postoperative complications of major orthopedic surgery. In the general population without thromboprophylaxis, the rate of subclinical VTE has been estimated to range between 40 and 60%, which is quite high. The risk of symptomatic VTE up to 35 days post-surgery has been estimated to 4.3%. So that providing pharmacological prophylaxis with low molecular weight heparin or DOACs is standard of care in most countries and in most patients. With respect to patients with hemophilia, well, clearly they are often considered to be at low risk of postoperative thromboembolic complication, and there is a big debate whether these patients should be on a thromboprophylaxis post-major orthopedic surgery. So what do we know from the literature about the risk of symptomatic VTE in patients with hemophilia undergoing major orthopedic surgery? So this is on this slide a summary of the existing literature. So there have been a few studies with quite a large numbers of procedures investigated, and as you can see here, most of these patients did not receive pharmacological thromboprophylaxis, and the rate of VTE, symptomatic, so clinically obvious, was quite low, ranging from something like 0.7% to 1.4%. In our view, it's more interesting to look at the incidence of subclinical DVT. I mean DVT diagnosed by imaging in these patients, and there have been a few studies. One by our group in 2010, we reported a small series of 29 procedures, and we found 3 subclinical DVT in patients who did not receive pharmacological thromboprophylaxis. There was another study from Takedani, Japan, a little bit later, 46 patients, and again, in the absence of pharmacological thromboprophylaxis, there was no subclinical DVT, and a more recent study by Buckner, where they found 1 symptomatic DVT and no asymptomatic DVT. So the purpose of our study was to evaluate the incidence of subclinical DVT in patients with hemophilia undergoing major orthopedic surgery in the absence of pharmacological thromboprophylaxis. So this is a study performed in a single center. We enrolled all the patients, followed since 2002. All these patients are adult patients. None of them had a personal family history of VTE, and no thrombophilia workup was performed before surgery. So this slide shows you our population. So in total, we had 66 procedures, mainly involving hemophilia A patients, and most of these patients had severe hemophilia A, as you can see here. With respect to the age, the median age was 46, and you can see here all the surgical procedures that were performed. So mainly knee surgery, hip surgery, and few patients had also ankle arthrodesis or lumbar spine surgery. Patients received, most of them received tranexamic acid, low dose. Use of prophylaxis with low molecular weight heparin was quite limited, only 2 patients. And these patients were treated with continuous infusion of factor VIII or factor IX. So this slide shows you that how we could maintain factor VIII, factor IX level around 80 to 100%, although sometimes higher levels were reached. So that was delivered through a central line and continuous infusion. Patients received mechanical thromboprophylaxis by wearing compression stockings, so there was no compression. Rehabilitation was started early, and systematic Doppler was done between day 1 and day 14, usually day 7. So the results, there was no clinical DVT or PE. Subclinical DVT was detected in 5 patients, and the overall incidence was quite low. It was 7.5%. This slide shows you the detail of the 5 patients who had a DVT. So he had 4 patients with hemophilia A, 1 patient with hemophilia B. The A patient mainly had severe hemophilia, and most of this DVT were observed after knee arthroplasty. And as you can see at the bottom of the slide, 3 of these clots resolved spontaneously, and for 2 patients, we decided to treat them with a short course of low molecular heparin. So what can we discuss from this? Well, that clearly there is a very low rate of circumferential DVT. This is clearly a large study, and with a systematic EOS Doppler in all patients around day 7. There are some limitations. It's a single center trial, mainly patients with hemophilia A, and there was no US Doppler performed on day 30 or 35, but all these patients were reviewed on day 35 clinically, and there was no delayed DVT that was diagnosed. So what can we say about this? Well, that the risk of DVT in these patients is clearly lower. Clearly, patients with hemophilia probably have an inherent protection due to their deficiency. These patients are young, and also rehabilitation was started early, and patients received mechanical thromboprophylaxis. But we should not underestimate the risk. Patients could still be at risk, and clearly in patients with hemophilia A, you should make sure that you maintain factor VIII level below 100%. That's not always that easy, and in patients with hemophilia B, well, clearly factor VIII could reach much higher levels. There is also a concern that some patients might have thrombophilia, although our policy is not to screen our patients for thrombophilia before surgery, and clearly other risk factors should be considered, such as cancer, personal family history of DVT. So what can we conclude? Well, that the study shows low risk of subclinical DVT following major orthopedic surgery, that systematic pharmacological thromboprophylaxis in this setting is probably not needed in most patients, but it's clear that in well-characterized patients with a higher risks, maybe that should be considered, but with a careful balance of the risk of thrombosis and the risk of bleeding. I stop here, and I thank you for your attention.
Thank you very much, Dr. Hermans, for a fantastic study. This is a much needed work in hemophilia. This is a question that is always present in forums where we talk about joint reconstruction, and we'll get back to the paper in the question and answers section of this segment of the country. I will now have the pleasure of introducing Dr. Jenny Zhou, who will be presenting a paper by the title Bleeding with Iron Deposition and Vascular Remodeling in Subchondral Cysts, a newly discovered feature unique to hemophilic arthropathy. Welcome, Dr. Zhou.
Thank you. So on behalf of my co-authors, I'd like to present our work, and I have no disclosures. So some background: subchondral bone cysts, which are described as cavitary lesions in the subchondral bone, have been a widely described but poorly understood feature of osteoarthritis. Subchondral bone sclerosis, together with progressive cartilage degradation, are considered to be cardinal features of OA, and in several studies, the cyst number and volume have been associated with increased cartilage loss, disease severity, and are overall thought to play a role in the pathogenesis of OA. However, the occurrence and potential implications of these subchondral cysts in hemophilic arthropathy are unknown and have not been fully studied, though they have been described in the literature. We do know that vascular remodeling with hemosiderin deposition in the synovium is considered a hallmark feature of hemophilic arthropathy. Recent studies from our lab have shown the presence of iron accumulation beyond the synovium in the cartilage in patients with hemophilia who underwent joint MRI T2 star sequence imaging. This finding correlated to worsening joint health by the Hemophilia Joint Health Score. Furthermore, we have also clinically observed the presence of hemosiderin deposition within these cysts by MRI in these patients with hemophilia. Overall, this has led us to postulate on the role of iron accumulation beyond the synovium in the bone microarchitecture, such as subchondral cysts. Based on these observations, we aim to systematically evaluate cystic iron accumulation to determine the extent of possible bleeding into the cysts and discuss potential implications for the progression of hemophilic arthropathy. For our methods, MR imaging of arthropathic joints of 35 patients with hemophilia were prospectively and independently reviewed by 2 musculoskeletal radiologists for the presence of hemosiderin. Then MR imaging of arthropathic knees of 16 patients with hemophilia were matched to the knees of 16 patients with OA to determine cyst volume and hemosiderin deposition. And finally, explanted joint tissue from joint replacement surgery from 3 patients with hemophilia were matched with 3 patients with OA for histologic analysis. For both the MR imaging and histology, patients with hemophilia were matched by gender and radiographic Kellgren-Lawrence score to the OA patients. The Kellgren-Lawrence score is a common method of classifying disease severity in OA radiographically. The joint tissues were overlaid digitally with the preoperative MRI, CT images, and photographs to ensure matched regions of interest and planes for sectioning and histology. For histology, the bone pieces were fixed and decalcified with a Pearls or Prussian blue reaction to detect the presence of ferric iron. Immunohistochemistry for alpha smooth muscle actin, which is a marker for vascular remodeling, and CD68, a pan-macrophage marker, was done before counterstaining with total a cell nuclear stain hematoxylin. The iron deposition within each cyst was then quantified, and total alpha SMA vessel count was also defined over the total cyst area with attention to vessels greater than or equal to 20 micrometers and 40 micrometers in diameter. Finally, cell count by CD68 and total cell count by hematoxylin was obtained over a defined region of interest encompassing each cyst. For our statistical analysis, the data are expressed as mean plus standard error, and differences between groups were compared by Mann-Whitney. Results. MR imaging revealed the presence of hemosiderin in subchondral cysts in 28 out of 35 of the examined hemophilic joints. Upon MR imaging of the 16 knees in the patients with hemophilia compared to the 16 knees in OA patients, there was overall significantly higher cyst burden as by composite cyst score by the whole organ magnetic resonance imaging scoring, as shown in the figure. Furthermore, hemosiderin deposition was present in 7 out of 16 knees in patients with hemophilia compared to 0 out of 16 in the OA patients. This is a representative example of an MR imaging of the knee of a 37-year-old patient with severe hemophilic arthropathy on top and a 73-year-old patient with severe OA on the bottom. As you can see in the patient with hemophilia, the cysts that are lining the medial femoral condyle and tibial plateau have a pronounced hypointense lining as delineated by the yellow arrows. This is consistent with the presence of hemosiderin. In contrast, in the OA patient on the bottom, there is overall less cyst burden, and the cysts do not have this hypointense lining on either T1 or T2 weighted images. In terms of the explanted joint tissue for histology from the 3 patients with hemophilia and the 3 OA patients, these are the patient characteristics. As you can see, the OA patient has a median overall older age, as to be expected. The hemophilia patients included 1 patient with moderate hemophilia A and 2 patients with severe hemophilia A and B. The joints examined were knee, femur, and shoulder in the hemophilia patients and knees in the OA patients. And the degree of arthropathy by the adopted Kellgren-Lawrence score was 1 moderate and 2 severe in both groups. In terms of histologic analysis of the cyst, as you can see in the patients with hemophilia, there is significantly increased vascular remodeling by alpha SMA vessel count in the top figure and iron deposition by Pearl's quantification compared to the OA joints. On the bottom figure, there seems to be a comparable CD68 or macrophage cell count and total cell count within the cyst between the two groups. The extent of vascular remodeling was evident with a higher number of alpha SMA vessels that were greater than or equal to 20 micrometers in diameter, with a trend towards significance for those with a diameter greater than 40 micrometers in the hemophilia joints compared to the OA joints, signifying a higher proportion of larger remodeled vessels. For reference, a normal vessel in the synovium has a diameter of about 10 to 20 micrometers. The bottom figure shows a representative example of these alpha SMA remodeled vessels within the cyst of a patient with hemophilia. These are representative examples of cysts in a patient with hemophilia in the top row and an OA patient on the bottom row. As you can see, in the hemophilia patient, there is significantly increased alpha SMA positive vessels as stained in red and iron deposition throughout as stained in blue in the patient with hemophilia with a comparable cellular content compared to the OA patient. In conclusion, vascular remodeling with hemosiderin deposition in the synovium is considered a hallmark feature of hemophilic arthropathy, but to date has not been described in subchondral cysts. Our observations suggest the occurrence of bleeding into subchondral cysts, evident by pronounced iron deposition and vascular remodeling that appears to be unique to hemophilic arthropathy compared to OA, both by MR imaging and histologic comparisons. This would seem to suggest that joint bleeding may not just be intracavitary as traditionally thought, but may also involve intraosseous structures. Further elucidating the effects of osteochondral and subchondral iron deposition to bone remodeling specific to hemophilic arthropathy could potentially have important implications in the progression of underlying disease. This would require additional studies with a new focus on cyst pathology and bleeding. And finally, I'd like to thank my mentor, Dr. Vandra Galsi, our collaborators in San Diego, and the World Federation of Hemophilia for allowing me to present my work. Thank you.
Thank you very much, Dr. Zhou, for an extraordinary presentation, an elegant study, extraordinary immunohistochemistry, tremendous insight in terms of joint pathology and what's really going on with hemophilia. And once again, we'll get back to asking questions later on during the presentation. I will now have the honor of introducing Dr. Ozgur Bakan, who will present a paper titled Simultaneous Total Hip and Knee Arthroplasty in Hemophiliacs. Welcome, Dr. Bakan.
Good evening and morning. Can you hear me? I am Dr. Ozgur Mert Bakan. I am a resident doctor in the Orthopedics and Traumatology Department of Ege University Hospital from Izmir, Turkey. Today, I would like to present you our study, Simultaneous Total Hip and Knee Arthroplasties in Hemophiliacs. Hemophiliac patients frequently suffer from severe arthropathies involving multiple joints. Most commonly involved joints are knees, ankles, and elbows. Not as much as these, but hips could also be affected. Hemophilic arthropathy is a disease of young men affecting their quality of life and functional status. Most of these arthropathies could be only treated with arthroplasty procedures. Whenever it's possible, performing multiple operations in one session is preferred in hemophiliacs because it provides a faster solution it's more tolerable for the patient, facilitates rehabilitation process, and it's cost effective. Why simultaneous? Because it provides faster and easier outcome, it provides faster and easier rehabilitation and patient satisfaction, and it's cost effective. Aim of this study was to compare preoperative and postoperative, objective and subjective measures in hemophiliacs who had simultaneous total hip and knee arthroplasties. Patients and methods. In this study, the hemophiliac patients who had primary total hip and knee arthroplasties between 2002 and 2018 were retrospectively reviewed. There were 45 primary TKAs, 30 patients, and 8 total hip arthroplasty, 8 patients, and 5 of 8 patients had simultaneous total knee arthroplasty. 2 patients had also knee arthroplasty, but in other session, and the final patient had no total knee arthroplasty. One patient was deceased in the early postoperative period as a result of prolonged gastrointestinal bleeding due to liver cirrhosis, secondary to hepatitis C. Therefore, 4 patients were evaluated for in this study. 3 simultaneous procedures were ipsilateral and 1 was contralateral. All patients had severe hemophilia A. None had factor inhibitor. 2 patients had negative viral serology, however, 1 was Hep B and 2 were Hep C. And patient 4 has connective tissue pathology. We lost patient 5 due to prolonged postoperative gastrointestinal bleeding. This patient had a history of hepatitis C and had developed liver cirrhosis. Preoperative consultations with gastroenterology revealed that it was safe for him to undergo arthroplasty procedures at that time. Nevertheless, the patient was deceased in the early postoperative period as a consequence of a bleeding complication. Mean age of patients was 80 and our mean follow-up duration 60 months. So, preoperative and final follow-up comparisons were performed by means of Harris Hip Score, Knee Society Knee and Function Score, Knee Injury and Osteoarthritis Outcome Score, KUS, Visual Analog Scale VAS for knee pain, and hospitalization duration and postoperative blood transfusion amounts were reviewed. Statistical analyses were performed utilizing SPSS, and Wilcoxon sign rank test was used. Results. By means of both objective and measurements including Harris Hip Score and Knee Society Score and subjective measurements such as KUS and VAS, the patients had experienced substantial improvements. For hips, mean Harris score increased from 45 to 75. For knees, mean knee score increased from 36 to 69. For knees, mean knee society function score increased from 50 to 73. For knees, total KUS score increased from 34 to 82, and mean VAS score decreased from 6 to 1. Since the number of patients were limited, it was not possible to reach a statistical significance to demonstrate the achievements experienced both by the physician and patients themselves. Every patient had an increased Harris Hip score postoperatively when compared to the preoperative scores. Qs were also increased postoperatively. Every patient had an increased knee and function scores postoperatively when compared to the preoperative scores. By means of range of motion, each patient had achieved increases at varying degrees. All of the patients had a flexion contracture of their knees preoperatively. All but one had this problem resolved postoperatively. One of the patients, patient 4, had experienced a wound healing problem at the level of his knee, which was treated with gastrocnemius flap. He had a residual flexion contracture. Mean hospitalization duration was 18 days and mean amount of blood transfusion was approximately 7 units. Here is an example of our case series. Patient 3, he was 57 years old at the time of the operation, and his right hip and both of his knees were symptomatic, but his left knee was more severe at the time of operation. He had pain and limited range of motion. Here in this slide, in fact, we have walking video, but it's not possible now. And you see preoperative and postoperative X-rays of the patient who had simultaneous contralateral arthroplasties of her right hip and left knee. Conclusion. Simultaneous procedures offer several advantages for the patient, physician, and even for the society due to the cost effectiveness. However, multiple procedures are prone to multiple problems. You see the advantages of simultaneous procedures: functional gains, easier and faster rehabilitation, cost effectiveness, and improved patient satisfaction. And this is the disadvantages of simultaneous procedures: increased complication risk and problems related to associated disease and comorbidities. When performing surgeries in the hemophiliac patients, complication risk is always an issue. Based on our experiences with hemophiliac patient population, simultaneous procedures should be reserved for the convenient patients. Associated health issues should always be considered. Collaboration with hematology team is essential. Thank you for your kind attention.
Thank you very much, Dr. Bakan, for a wonderful presentation. It requires a lot of coordination and experience in a hemophilia care team to be able to do extensive reconstructive procedures, which includes simultaneous procedures like the one you described. And we'll get back to asking some challenging questions to you in a few minutes. I will now have the pleasure of introducing Dr. Kumiko Ono, who will be talking about another very complex procedure. The title of the presentation is The Indication of a VY quadricephaly for total knee arthroplasty in hemophilic patients with stiff knees. This is something we haven't heard in this scenario for a while, and we look forward to listening to this interesting presentation. Welcome, Dr. Ono.
Thank you, Dr. Llinas. So, good morning, good afternoon, and good evening, everyone. I'm an orthopedic surgeon from Tokyo. So, I appreciate the opportunity to present at online meeting. So today I'd like to talk about the indication of VI quadriceps plasty for total knee arthroplasty in hemophilic patients with stiff knees. I have no disclosures. First of all, the knee is the most involved joint responsible for pain and disability. With hemophilic patients, total knee arthroplasty (TKA) for hemophilic patients have many advantages, not only pain relief, but good outcome and improving QOL. On the other hand, TKA is now challenging procedure because of severe deformity and contracture, high complications after TKA. One of the TKA difficulties is contracture, stiff knee. Knee stiffness defined by a preoperative range of motion, ROM, less than 50 degrees. Preoperative ROM is the most significant predictor of postoperative function following TKA. But the problem for stiff knee is surgical approach. Medial parapatellar approach, this is normal TKA approach, becomes difficult or even impossible to perform in patients with stiff knee. So one method for stiff knee is VY quadriceps plasty, VY. This is lengthening of the extensor mechanism by turn down of the quadriceps shaped VY. We reviewed hemophilic TKAs during 2017 to 19 in our hospital. We performed 65 primary TKA in 53 patients. Preoperative ROM 50 degrees or more were 49 knees, and 16 knees were less than 50 degree stiff knee. Now we focused on these 16 knees. We performed 8 knees by normal, medial parapatellar approach TKA, and other 8 knees by VY. Our aim of this study is to optimize 16 TKA procedures for stiff knees with hemophilic patients by evaluating the pre-post factors retrospectively. Evaluation items are here. ROM means arc of flexion to extension of knee. We evaluated knee at pre-operation and 1 month post-operation. Wilcoxon sign rank tests were performed between TKA and VY and pre and post-operation. Result. This is demographic data, normal TKA and VY TKA. Age, type of hemophilia, severity, inhibitor are no difference between normal and VY. Pre-ROM and pre-flexion were superior to normal than VY. Surgical time and bleeding of surgery are no difference. Post-ROM and post-flexion were superior to normal than VY. Comparison between pre and post-operation knee evaluation. Yellow line shows normal TKA and Blue line, VYTKA. Left bars, pre-operation. Right bars, post-operation. First, in normal TKA, post-ROM, flexion and extension improved significantly than pre. On the other hand, in VYTKA, post-ROM and flexion improved significantly. Extension was no difference between pre and post. Discussion. Focusing on pre-operative ROM of stiff knee TKA with hemophilia, Strauss reported VYTKA was about 18 degrees and normal TKA was 33 degrees. This result is almost the same as ours. VY 13 degrees and normal 34 degrees. And IQR of our study, VY was 5 to 23 degrees and normal 25 to 40 degrees. So ROM less than 25 degrees become a guide to the indication of VYTKA. We have to be careful about extension lag of post-VYTKA. Previously, with hemophilia, post-operative extension lag was 7 degrees. And without hemophilia, persistent extension lag in 5 of 14 patients. In our study, 4 of 8 knees found extension lag at 1 month. VY is associated with the development of post-operative extension lag. I'll show you a VY case. 67 years old male with hemophilia A. He has no history of inhibitor. His left knee was end-stage valgus arthropathy. We performed VY-TKA. This picture shows a patellar eversion by cutting down shaped VY quadriceps. Surgery time 67 minutes and bleeding during surgery for 22 milliliter. ROM improved from 15 to 65 degree. Extension lag 10 degree at 1 month. This study has limitations, a small sample size, and short outcome. Conclusions. 8 knees of 16 TKAs were performed by VY quadriceps plasty for stiff knee patients between 2007 and 19. VY was significantly improved of post-TK ROM compared to pre as well normal TK. VY is essential surgical technique for hemophilic stiff knee, especially less than 25 degree pre-ROM. Thank you for attention.
Ça m'avait demandé pour le Maroc et le Bénin.
Well, thank you. Thank you very much, Dr. Ono, for an extraordinary presentation. I want to ask all the speakers to mute their mics, except that one with whom I'm speaking at this point. I'm going to ask a number of questions. I'm going to start in the order of presentations. So I'm going to go back to Dr. Hermans now. And so imagine, Dr. Hermans, that Dr. Bakan heard your presentation and you get a call from him from Turkey saying, you know, this was extraordinary presentation, but I want to ask you a question. And the question, Bakan, you know, he's a resident and they ask difficult questions. I have a patient that I'm going to do surgery now, total knee replacement. or even better, a total hip replacement. And he had pulmonary embolism before. He's a severe hemophiliac, and he has a history of pulmonary embolism. So what do you advise?
Well, if this is quite an unusual presentation, I'm not aware of that many patients with hemophilia who have had a PE, but if this is the case, I think the patient should be substituted with factor VIII, but at the same time receive thromboprophylaxis. I would give thromboprophylaxis in that setting. If there is a past history, or if the patient has multiple risk factors, I would consider thromboprophylaxis. If this is not the case, I would not.
Okay, well, it hasn't been long since you hang up the phone, and then you get another call from a surgeon who says that he follows religiously the guidelines from the American Academy of Orthopedic Surgeons. And he says he's going to do surgery in a patient with hemophilia, and he wants to use aspirin because it's been recommended in a very assertive manner by his academy. And so what do you advise the surgeon?
Well, I'm not sure that aspirin would be helpful in this kind of setting. I would not recommend to do that. I'm not sure that if in the absence of risk factors that these patients really need thromboprophylaxis. And personally, I'm not convinced that aspirin would be the ideal agent in this setting. That would be my personal advice. But I know there is a big debate about this.
Okay. And I wanted to ask you, in those few cases where you found subclinical deep venous thrombosis, how did you manage them afterwards?
So for 3 of them, the clot was so small that we decided not to do anything. For 2 other patients, the clot was a little bit more extensive, and usually it involved several veins, so we decided to treat them, but with a low dose, a half therapeutic dose of low molecular heparin for a short course. That's how we managed this, and the clot totally resolved with this. So it was not really an aggressive treatment and not a systematic treatment.
And perhaps a last question, since we have you here, and it's such a treat to have you and be able to ask questions to you. You were talking about mechanical thromboprophylaxis. So it's a continuous sequential compression device, most likely. And I think all of the surgeons who are listening to you, and many of the clinicians have the question as to how much of that do you actually give the patient? I remember a reference from the chest guidelines that suggested 18 hours of a day of mechanical prophylaxis. And we know of the challenges of getting adherence and tolerance to this technique. So 2 questions. One, how many hours a day do you actually measure and count as compliance? And how high do you go with your mechanical device? Do you use foot and ankle or calf level or thigh level devices?
Well, just to maybe I was not clear, but in our center we only use stockings in our center. We didn't use, this mechanical compression. We didn't do this. And stockings, and honestly, we used to use them a lot in the past, but today, with the new technique, I have to admit that the patient is, so quickly recovering that we even do not feel that this is needed. So no mechanical compression in our center.
Okay,
But
that's
what we
very
do
clear.
for the moment, honestly, we perform an ultrasound systematically on all of these patients around between day 5 and day 10, a little bit before discharge, because these patients now stay in maybe 7 days, something like that. And before discharge, we perform an ultrasound. That's what we do, just to be completely sure.
Thank you very much. I'll move on to Dr. Zhou now, with such a beautiful study, such great histology and immunohistochemistry. I wanted to ask you if from the clinical perspective, you have suggestions for clinicians. Do you have insights as to how this documentation of a finding that we suspected that had not been measured modifies the way we treat patients?
Yeah, I think that it's still very early on, and so we're trying to delve deeper into these cysts and bleeding and the implications for underlying arthropathy. Potentially, in the future, if we do have a better understanding of this, more targeted therapies like intra-articular iron removal might be something to look at. But yeah, I think right now it's so early in our understanding of this.
So you're talking about chelating agents, pharmacology of this nature. Could you expound?
Yeah, so I mean, we've known, and there are studies that have shown that clotting factor replacement alone may not prevent the progression of hemophilic arthropathy, and some of it is postulated to be due to the fact that these iron deposits accumulate, in various structures in the joint cavity and potentially intraosseous structures. And so this is, just a hypothesis that has been thought of, is that potentially, chelating the iron and removing that toxic iron deposition may have a better effect.
Absolutely. What about hemochromatosis? Would there be some similarity that you anticipate?
So hemochromatosis is a systemic iron overload disease. You do see, decreased bone density and osteoporosis in hemochromatosis patients. There have been some small studies where they've actually found iron deposits within the bone mineralization fronts in patients with hemochromatosis. But again, there are very limited studies on the directly linking the effects of iron to bone remodeling. So, theoretically, there could be similarities in terms of iron causing bone issues and bone remodeling issues, but we don't know that yet.
Mm-hmm. Would you say that these iron deposition sort of overplays the images when it comes to MRIs? Sometimes we get early MRIs and you get this very sort of extraordinary images that sort of overplay the clinical condition of the patient. Do you think it's a mechanical artifice, or does it reflect reality?
I think it depends on the timing of the MRI in relation to the bleed, when the patient's last bleed was. So obviously, you might see more pronounced iron after a more acute episode, depending on when you get the imaging. But certainly the characteristic findings of hemosiderin deposition has been well described. So I think that is true.
Thank you very much. Thank you very much. I'm moving on to Dr. Bakan because he is a resident and we like to question residents very hard here. I'm sure it's the same in Turkey, so I'm sure he's used to this. So I'm going to start with a tough question. And Dr. Bakan, if one reviews the literature about bilateral simultaneous knee replacement, you find that it has a higher mortality than staged or delayed joint replacement. And we all understand the issues that are related to cost of the concentrate, especially if you live in a developing economy, which is I wouldn't say is the case for your country, but it may be the case for others. So how do you balance this increased risk of mortality with the practical elements? You mentioned a phrase which I thought was extraordinary. It was multiple procedures are prone to multiple problems. So being a young, enthusiastic resident, how do you balance those two?
Of course, the important one is patient health. And when we decide to perform simultaneous procedures, every time we check our patients with our anesthesiology, and when we finished our patients' hips, we check our anesthesiology and we asked what about patients' status, and if the anesthesiologist say to us, yes, it's okay, you can go on, and we think about that, and we go on to the to make the knee arthroplasty of the patient.
Okay, I think that's a very reasonable answer. We have a debate here in our center about that, and the challenge I have with that approach is that in a paper we all quote by Javad Parvisi, whom we all read in the reconstruction world, about half of the complications that were severe in cases like that were not predictable by the normal screening mechanisms. So there's, even if you do that and you screen carefully, there's always that risk. Now, Dr. Bakan, you get a call now from Dr. Ono from Tokyo, and she says, well, I heard your talk, and here in Tokyo we are doing VY quadriceplasties because we have trouble with range of motion and especially flexion. How do you get it done without what they do in Tokyo? Can you tell her?
Okay. Thank you. So stiffness is very difficult to get, but so friction is our result. Friction is improved significantly than pre. But so I think the difficulty is extension, and extension is not so good. So friction is good, but so extension is not so good. So ROM is result is good, good result. So we challenge it always, rehabilitations and friction rehabilitation.
Okay, I'm going to go back to Dr. Zhou for a moment because here we have two enthusiastic surgeons who are doing extensive procedures, and Dr. Zhou is very interested in basic sciences, and she's been publishing about vascular permeability and all sorts of very sophisticated basic sciences concepts, and there is some concern about the quality of healing in hemophilia. And so I would ask to you, what would you tell these two enthusiastic surgeons about healing in hemophilia? Is it abnormal in general, or is it something they can rely on and go ahead with these large procedures?
Yeah, I think that is a concern. With hemophilia, there can be some delayed healing, and depending on the extent of the procedure, we do see that sometimes. Whether the whether the blood products that remain from surgery, like if they're not removed locally, whether those can cause issues with healing is something that we think happens as well. But obviously with clotting factor, making sure the factor replacement is at the targeted levels is important. But certainly we do see sometimes issues with healing in these patients. And it's very variable though, and I think it really just also depends on the extent of the procedure.
Thank you very much. I'm going back to Dr. Bakan now because he's the resident and we like to question him. Dr. Bakan, what is your feeling in using implants, hinged implants for very stiff knees? And after you answer, I'll go to Dr. Ono for her opinion. So I'll start with Dr. Bakan. What do you feel about the relevance of hinged implants for very stiff knees like the ones you're doing? I think we lost your audio.
Sometimes we perform tuberostas tibia osteotomy for stiffness, because sometimes when patient consult to us, some patient had 0 degrees flexion, and some patient had ankylosis of their knees. When we see this patient and we have planning to tuberous tibia osteotomy and preoperative planning.
Okay, and I'll go to Dr. Ono now. How do you feel about using hinged knee implants?
I think hinge implant is a good choice, but the problem is we focused on bone stock. So bone is not bad. So we choose not hinge type TKA first, not constraint type, and second or third TKA is choice. I think so. So because the hemophilia patients are relatively younger, and so if bone is not bad, and so not absence from the articular bone, so we choose first choice is not constraint type.
Okay. Tell us a little bit more, please, about how do you protect your patients when they actually have an extensor lag and they face the risk of buckling and falling. Yeah, this is a very disabling situation. I understand it is transitory, but still it's very difficult to handle. How do you work with the patients and how do you protect them? How do you rehabilitate the patient?
Yes, so it's very difficult. So because hemophilic patients, so multi-arthropathy and not only knee, but ankle or ankle ankylosis. So the surgery method is very important, not to overlength the quadriceps, the extensor mechanism, not too much length to avoid a permanent extensor lag, and many rehabilitation. I think so.
Okay. Thank you very much. I would like to go back for a final question to Dr. Hermans. That's a general remark, if you will, about new approaches to treatment in hemophilia and any concern that we should have in terms of clotting or thrombosis in large reconstructive procedures. Do you see danger? Do you see risk? Do you see a specific condition arising that we may be or should be aware of?
Well, with respect to emicizumab, the bispecific antibody, I don't think it's a major issue because it mimics factor VIII, but I would be much more concerned by using what we call the rebalancing agents, by targeting TFPI or even more antithrombin. So I think these patients might be at risk. So I would not be very confident to decide that the patient should undergo major orthopedic surgery while being on anti-TFPI or having low antithrombin levels. So this is a concern, in my view. The future will tell us, but I think there are some reasons to believe that could increase the thrombotic potential. I think these drugs are quite nice if the sky is blue, if there is no problem, but at time of surgery there will be a release exposure of tissue factor, and I think that at that time you need TFPI and you need antithrombin working to downplay the coagulation process. So that's my perception, but this is a bit speculative because it's not supported by data. I don't know what your opinion is.
Well, when I want to foresee the future, I talk to you. So I'll stop there, and I want to thank you all, wonderful colleagues, for a great session. I think we've learned a lot. I hope the audience has had an extraordinary experience. And we thank WFH for this opportunity of seeing all of you and interacting in this virtual summit. Thank you very much.
Thank you. Bye-bye.
Thank you.
Thank you.
Thank you. Bye-bye.